sort of flow chart that I made to help based on feedback from last year's, you know, that we don't know if it's a simple, moderate, or complex case, and how do you work it out. You know, I suppose most of you have had a look. So this is a very simplistic version. So if I told you to follow this flow chart, you'd probably get it wrong a lot of times, because crowding is quite subjective, how you measure. Gingival biotype is subjective to some degree, and lower incisor, retroclined, you know, some cases, whether it's procline or retrocline, it can be a bit subjective. So these are things you learn throughout the year. But for now, this is a cookbook approach. So just know that if you just follow this cookbook, you may get it wrong, okay? But it's giving you some guidance right now. Towards end of the year, you'll start to really understand the complexities of each one of these parameters, how hard it is to really get an estimate of crowding, how gingival biotypes can be so variable, how low incisor position can be so variable, and in some cases cause recession and some not. So you will learn those kind of things over time. But for now, this is a baseline. So for those who are not familiar with Slack, I just want to say to you, you should do two things, okay? Install Slack on your desktop. I want you to go to the general channel. On the right-hand side, there's a tab called Files. When you go to Files, you can download all this stuff that I keep putting there. You can save it on your computer. You can go to Slack mobile and download these files and save them to Dropbox, or save them on your mobile phone under Files. So, you know, Slack is very easy to use. It's there. The documents are always there. You can search with the name and you can find it. So I want you all to really start using Slack, because we throw a lot of information there every day. Now, Kim is asking, will I be able to access the handouts so I don't have access to the learning portal? Good question, Kim. Can you take that offline, because you are just doing webinars, I know. Just email Hazel and she'll email it to you. Okay, so basically, this is a class 2 one, okay? Again, as a guideline, have it in the background. So if a class 2 patient comes to your clinic, you want to look at whether there's growth left or not. If there's growth left, what's the lower incisor position? You know, how proclined are they? Can we do functional appliances? If it's no growth left, how severe is the class 2? Okay, these are very broad categories, because you can get a class 2 skeletal with a class 1 dental. So again, this is a cookbook, and I don't like cookbooks. So for now, just use it as a guideline and kind of look at some scenarios, okay? But towards the year, this will all make sense. So has everyone had a look at this? Can I get some feedback? Has this been helpful, the 2 flow charts? Whether it's a moderate, simple, or complex case. Yeah? So Lily, yes, helpful. Yes, Janie, yes. Okay, perfect. Just remember, it's just a guide for now, and it'll become more clear to you later on, the complexities here. Okay, awesome. So please download this on your desktops, and you can have it there. You can have it in your practice. You could just have it in a folder, and you can reference this many times. So we've just got a few people saying yes, 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 they found it useful. So the purpose of today really is to walk you through, to be honest, the 2 PowerPoints you're going to do. Okay, so the 2 PowerPoints that you're going to submit, the level of records required, how do you submit it to me, you know, what is the best way? So it's kind of going through all of that. I'm also going to go over some record taking. You know, I'm not going to spend a lot of time here teaching that, because you're going to learn that in our in-office course. Also, course 1 will extend on this webinar. So what I'm teaching you here, you'll get the next level on course 1, okay? So the a lot more deeper. So by end of course 1, you'll be starting to go, I know how to start my PowerPoint, okay? So you may still not get it. Everybody has got this form in their downloads in Boss My Account. I'm pretty sure, is this form also on Talent LMS? Examination form. If it's not, it's in Boss My Account downloads. So please make sure you download this form. This is like a guide to help you examine a case, to create a problem list. You can have this in your practice. And actually in course 1, we'll go through every little bit on this form. So we'll be talking about what is symmetry, what is facial thirds, you know, what is, how do you look at skeletal maxilla mandible position, soft tissues, you know, what is the periodontal problem. So we'll talk about a lot of this, and we're going to put have a workshop on one of our cases. And as a group, we're going to develop a problem list for a patient, okay? So this will all make sense a lot more after course 1, but I'm going to start the process today. So this is an important form. So when you're giving me information about a patient, I really, really please do want you to fill this out. You may be incorrect, you may be correct, doesn't matter at this stage. But just have a go. It could just be subjective. It could just be, you know, I don't really know what you're saying here. Just try to have a go. Because if you don't have a go, I don't understand your level of learning and how I can help you and how we can kind of get a really good case analysis and learning for you. So these 2 forms, if you're sending me a patient for screening, some of you have, about 10 to 15 people have now sent me photographs, and that's okay, all right? But for screening, I'm happy to just look at photographs on Slack, and I respond straight away, and I go, good case, but photos aren't good, you need to do better photos, or, you know, you haven't given me enough information. I have been very responsive on Slack. What I do want is if I say it's a good case, and if I say, you know what, this could be one of your PowerPoints for the end of the year, I want you to start filling this out. This is what I need next. I want you to fill these 2 pages out, okay? I've had some people just say, I found a case, here's the digital Invisalign plan, can you treatment plan this? That's a late position for me to come. You've already somehow diagnosed and you think you've already got it. That's not the way I want you to learn, because if you just get me straight into treatment planning, we haven't gone through the process of learning diagnosis. So I think that's not a position where I want to come in. I want to come in here. I want to see these 2 things filled out. Once we say, this is a good case, go get started. So far, so good, yeah? So everybody can download this, print it out in your practice, have a few around so you can write this down and go through this examination. So today we're gonna look a little bit into records and photography. You know, then what's a problem list? How do we do it? And we're gonna have a workshop in course 1. We're gonna talk a lot more about this. And we're going to talk a bit about smile design and treatment planning. So we're going to do an overview of these PowerPoints. I'm going to finish by showing you a case from last year's BOSS attendee. And I'm going to show you the level of records, the level of detail, and the level of planning here. Okay, so it gives you an idea of where we're heading. So first and foremost, the photographs have to be really, really good. Okay, you don't have to give me excellence, but you have to give good. Okay, and now this is one of our patients. You can create a format like this, or you can drop them in PowerPoint. You've got the PowerPoint template, and you can literally drag and drop these photos. Okay, you can edit them in PowerPoint. You can flip them. I've had people send me occlusal shots not flipped, the other way around, and I have to turn my head 180 degrees to look at them. And you know, it confuses me, because I'm like, hey, that's 1-2 or 2-2 because it hasn't been flipped properly. And you know, if we're going to look at record taking, it's got to be good. So, and I'm going to help you get to that level, but please get a good camera, good retractors. You know, retractors aren't very expensive. Learn the right technique. Do good photography. Don't give me photographs with shadows. At this point in time, some people I've messaged back and said, these photos aren't good. These photos are not good. So you've got to kind of look at how to improve it, right? Because I'm diagnosing everything off a photo. So they have to be very good. So photos can show us asymmetry. So you need to take them in a very standardized way, because if you take them a bit twisted, shadows, we're not getting a full sense of this patient. They need to be able to display accurately the patient's height and width proportion. I had some people send me photos that are so close up, it looks like the face is all curved. Okay, you can tell the distance wasn't appropriate. So the smile elements, we want to look at smile arc, the lip elevation. So the smile shot is so important. The first thing I'll say to anyone is send me the smile shot, and you've got to get a good smile. So there's a smile like here. I want this, right? I want to see a smile. So because everything we do, diagnose and treatment plan, is on that smile photograph. Some people even do smile videos. I'd rather you send me a quick video of them smiling. I really, really want the smile shot. So we've had a couple of boss attendees just slack me photographs, but they didn't take smile shots. And the first thing I said, what is the smile here? Because I can't even begin to help you unless I have a smile shot. Very important. You want to get some good soft tissue reflection. So I've had some people send me photographs, one cheek retracted, the other one not retracted. You can't do that, okay? So really lots of reflection. You want to see everything so well, okay? So it's not only important to treatment plan, okay? This is for medical legal considerations and for communicating. So if you're communicating with me, I rely a lot on your photography for giving you ideas. So Lily's question right now is, for a smile shot, is it a neutral smile or wider smile? So you were talking about posed and unposed. You know, either or will work. In fact, unposed is even better. Unposed is like a very emotional smile, but it's hard to elicit that in an environment. So, you know, especially in a clinical environment. So posed smile is okay. So you just tell them to not hold back, really smile when they're happy, and you make sure you capture it. Even if they say, I don't like smiling, you know, I tell my patients, this is the most important shot. I need you to give me the big smile that you can, okay? You can tell the difference between posed and unposed. So as long as it's a good smile shot. Now, we've got a YouTube video in your e-learning portal. This is also on our Boss YouTube channel. I won't play this entire video, but it actually has been so useful to dentists. I've had a few dentists email me, said, hey, we trained our team using your video. And this video, I'm training one new staff member, and she had never taken photos before, and she took nearly perfect photos, you know, for the first time. So you can see the whole technique, the reflection, the mirror. It's in your e-learning portal under Course 1 Core. Okay, so you really want to watch this YouTube video. It's Boss YouTube channel. You can share it around, show it to your staff. You want to watch this 2 or 3 times and really get how to do good photos. All right, so I'm not going to play this entire video, but I'll show you.
Little commentary as we go along. But so our camera is on. We have Juliana here taking the photographs. Okay, so firstly, with the camera settings, okay, so make sure that the settings, you want to show us the settings? Now our camera, so our camera is on, that's our settings, okay? Now it differs, everybody would have a different setting. Now the reason being is the lighting in your room. So we have adjusted our camera to oral photos, and I'm going to show you the photographs. So let's go. Are you ready, Nita? Yep, I'm ready. Just bear in mind the patient doesn't know what they have to do, so give me some guidance, some information, how to sit and what exactly to do.
Okay, no problem. I'll just ask you to have a neutral face for me, please, to take the first picture.
So the first one's just frontal at rest. You want to come straight at the patient's eye. That's beautiful. So can we see the picture again? Yes, you can see both ears are projected equally. Okay, so that's front on. Okay, that's a good picture. We're going to take the next one.
Okay, for the next one, can you just give me a big smile, please? Can you just show your teeth to me?
So she's being difficult here.
Okay, so again. This one, her eyes was not in the camera. That's a better shot. Again, you can see the 2 ears on left and right. So you know the patient's head was in natural head posture, looking straight ahead at the camera, and the camera was level. So that's a good shot.
All right, guys. So I won't play this entire video because you got the YouTube channel. I want you to watch it. And then it goes into intraoral, okay? So it shows how to retract. So I'm just gonna move forward with it, okay? Some of you have DSLRs. I don't think iPhones are appropriate for photography for dentistry. And unless you worked out a system with a ring flash and you've got a good macro lens, you know, I'm happy as long as we get the photos, right? So to my knowledge, DSLR is still the best. So we have a Canon 500D, we've got a macro ring. There's only one that comes for Canon. The lens is a macro lens, 100mm. Again, you know, you could buy whatever. You might have a Nikon in your practice, but you really want to do good photography because not only this will help you restorative, it will also help you with ortho. The recommended retractors is from, they're very cheap from OSC company. You can go online and order them. And they're V-shaped, okay? So they're like these deep V shapes. They really retract very well. It's all in your inventory list under downloads in Boss account. You've got these lip retractor. There's nothing worse than lips falling on teeth and you're sending me occlusals, but I can't see half the teeth. You want a lip retractor in there for occlusals. Okay, good mirrors. Always remember, you're taking any mirror shot, you've got to flip it. You can't actually just send it unprocessed because that's not professional. Secondly, that confuses the second person. So when you send me something unflipped, not formatted, not edited, I'm quite confused, okay? So occlusal, you do a vertical flip. You can do it in PowerPoint. You can do it in Preview in Mac. You can do it in, was it Windows Photo in PC? Photo Viewer. You can literally flip, okay? So easy. So occlusal with vertical flip. If you're doing buccal shots with mirror, horizontal flip. So please make sure they're flipped. This is how really photographs should look like, or if you want to send me study models, or some people send me, you know, Invisalign digital setups and they take screenshots of the 3 sides. Upper always pointing up, lower always pointing down. Okay, so that's really how you want your photographs to be, literally matching these models. You want as much reflection as possible. Ceph quality, I won't go much about it, but just make sure if you're taking Cephs, and Cephs are really recommended at this stage for, unless it's a very mild class 1, okay, with under 5-6 millimeters of crowding. The moment you see a skeletal imbalance, a class 2 or very procline incisors, or anything a bit unusual, just take a Ceph for now. And we'll go over cephalometrics in next webinar. So quality has to be really good. No point taking an image that's not sharp. We'll talk a bit more about this in course 1. You're taking Ceph to screen the airway. You're looking at adenoids and tonsils. You're looking at incisor positions and angulations. Okay, and you also want them natural head positions. So they're looking at their own eyes in a mirror. So this is really what photographs should do. You shouldn't really, the only reason I take a Ceph is nowadays to see airway, okay? Other than that, my Ceph should not need to confirm diagnosis, it just supplements it. So I'm looking at this girl, I already know she's class 3, she's concave profile, okay? She's mesofacial, she's not brachy or dolicho. She's got malar flatness, so she's got a retrognathic maxilla. And really, my Ceph is just there to confirm it or supplement it, sorry. You know, the photograph has already given me the entire picture. So learn to get really good with photography and diagnose things off pictures, your camera pictures. OPGs, definitely a must. You cannot do treatment without an OPG. Bite wings are even better if you add bite wings to make sure the caries risk is really low. Because OPGs are good for screening for perio, looking at impacted teeth, looking at root morphologies, any curved roots, any existing root resorption, eruption status. So, you know, OPGs are kind of must. And I also teach you to do them every 9 to 12 months in treatment. So, you know, we'll talk a bit more about that as we go along. There's a lot to take in today. So first thing when you get to diagnosis, right, you've got those 2 sheets you need to fill out. And those 2 sheets are asking you questions. What is the patient's actual need? So some of the questions you really want to answer before even starting treatment or thinking about it is, how long has this patient had this problem for? How long they've had crooked teeth? What has been the impact of it? Like, you know, do they, you can ask it very directly, has this impacted your life? How does it make you feel? What are the functional effects? Do they have any issues with, you know, chewing, anything like that, swallowing? Have they considered previous treatment? Because why now? Why are they accessing you for treatment now? You know, what is their motivation and compliance? I want to know, will they wear elastics? Will they change their oral hygiene? Will they change their diet? What is the age? Because we need to set realistic goals. When someone's older, you may not be able to completely correct a full class 2 that easily. And what is their expectation of the final result, you know? And have you discussed stability with them? So these are little guidelines of really understanding your patients, and you've got to fill some of this out in your exam sheets, which then gets transferred over to your PowerPoint, okay? So some of the questions we ask our new patients are, you know, what brings you here? Why me? Why now? And then we show them a mirror. We said, tell me everything that bothers you, not just one tooth. I want to see everything that bothers you right now. What's the one thing you would prioritize? You know, what do you want fixed first and why? How does this affect your social and daily life? What is the successful outcome to you? What would make you happy? So it's really important to know. And when do you want this by? So these are things that actually sets the ground for our treatment planning, because if we don't go this deep and they just say straight teeth, I just want a better smile, I don't accept that. I don't think that's a good enough understanding of the needs of the patient. And I think you're more likely to have miscommunication and breakdowns towards treatment end. So if you had this really crystal clear from day one, it'll improve your case acceptance as well. So it's part of a sales training I do as well. You know, you've got to really understand needs before showing them a solution. So this is a patient of ours who's basically come in for treatment. And the reason I'm showing her, because she's nearly perfect, and I'll tell you why she needs treatment. So firstly, you know, we took photographs, and I'm going to walk you through the process. So when you're taking photographs, frontal at rest, you can see how we've cropped it. You can see that all the unnecessary detail is gone. We've got a parallel line. Now you can do this in PowerPoint. You can actually just create a line that goes through the center of the both pupils. It's called interpupillary line, and that's your horizontal reference. Just a quick note, why do we choose this as horizontal reference? Because we know embryologically the eyes and the brain don't have as much asymmetry as much as the mandible. Okay, it's just nature's way of protecting the most vital structures. It's very rare to find people's eyes up and down. They're often quite symmetrical. So interpupillary line is supposed to be quite a nice horizontal reference. Then you drop a perpendicular line from interpupillary line around the soft tissue nasion, and it tries to give you an idea of, you know, midline shifts and things like that. So we want to be analyzing our photos. We want to look at, are these facial thirds equal? Some of you are more advanced practitioners here. You may follow this really quickly and well, but you really want to look at, is this a mesofacial patient? So mesofacial means that all the facial thirds as depicted here are equal. And the lower facial third, the upper lip covers a third of it, lower lip 2/3. So these are ideal facial vertical proportions. So you want to be able to get a sense whether this patient's brachyfacial, mesofacial, dolichofacial. Okay, this patient, question, is she brachyfacial, mesofacial, or dolichofacial? Can someone quickly tell me? What do we think she is?
Brachy.
Awesome. Thank you, Justin. So brachy, you know, reduced lower face height. She's very square in the jaw, everything pointing to, you know, you can call it hypodivergent growth pattern, brachyfacial. It's not brachycephalic, it's brachyfacial. That's the correct term. Obviously, if we open her lips, most likely we're going to see a deep anterior overbite because it's such reduced vertical here. We probably see an overclosed vertical occlusion. and you see these strong masseters. These are actually very difficult patients to open the bite for, okay? So, and often dentists will send me these to do veneers, so they want to do some veneers later on. They're quite difficult and challenging as adults. This one is the reverse. It's a dolichofacial. So completely hyperdivergent, long face height. You can see the lower facial thirds increase, and you can see that lip incompetency. Often they'll have some sort of open bite as well. Right, so you want to get a sense of these proportions. You can even look at vertical and profile. It doesn't have to be frontal. You can actually measure it in profile. So this is ideal vertical proportions. Okay, next thing you want to look at a frontal picture is asymmetry. So you want to get a sense of what are the different widths here. So how do we know? Well, basically we drop a lot of our horizontal lines and then we drop vertical lines. You know, quite easy to do in PowerPoint or any image editor. And you basically drop these long lines, make sure they're all 90 degrees so they're not slanted. And you want to drop medial canthus of the eye, outer canthus of the eye, verticals to the horizontal reference. And then you want to measure, you know, is this gonial angle on the left bigger than the right gonial angle? In this case, this is an extreme example because she's very symmetrical. You can see the 2 ears projecting. And if the left and the right side are off by more than 10, maybe 15%, you want to have a note of that. Like, for example, if the chin is deviated to the left by 15%, you know, if there's skeletal asymmetry, you can see it from a photograph if photographs are done well. So you want to pick up on that. Whether we treat that or ignore that, that's for later on. But you want to pick up on that and you want to add that to your sheet. You want to look at what is the soft tissue profile. There's an A point here and a B point. You know, are they equal? Are they convex? Is this concave? Is your horizontal interpupillary? Yes, interpupillary is the best reference for now. There are other horizontal references called Frankfurt horizontal, and I'll show you that. In profile, you can draw it. So Frankfurt horizontal is just above the tragus and the orbit, infraorbitali, and the soft tissue infraorbitali, but it's not the best reference. Interpupillary is a bit more embryologically safe and sound. So, but obviously from profile, you can't see interpupillary, so you'll have to draw Frankfurt horizontal, and you drop a perpendicular from soft tissue A point, which is the most concave part of the anterior projection of maxilla, and then you look at the difference between A and B point. What you're really trying to work out at the end of the day from these photographs is this patient convex, concave, you know, is the maxillary base retrognathic, is the mandibular base retrognathic? You're just trying to work that out. Now, again, a Ceph doesn't need to, the numbers need to not tell you this. You need to know this from your photographs. So that's why photography is so important. You know, in class 3, generally you'll see majority of patients will have retrognathic maxilla in Caucasians population. In Japan, most of the class 3 have a larger mandible. So the Japanese tend to have more genetic class 3. And even some, you know, Vietnamese, some Asians, they're more like pseudo class 3s. They just have more maxillary retrognathia rather than mandibular prognathia. So another way of looking at profile, you know, before we look at treatment planning, you really right now just think of this, just recording everything you see, you know, just record everything you see, whether it's normal, abnormal. Later on, we're going to develop the problem list. And when we do this in the workshop, it'll make more sense because we're going to do a whole workshop on it. Okay, so you want to look at E-line. E-line connects the tip of the nose to the tip of the chin, okay, just a tangent. And if the lips are 1 to 2 millimeters behind, that's good, or 0 to 2, sorry, behind. If the lips are forward of E-line, that's a protrusive profile. If they're more than 2 millimeters behind, there's a couple of things going on. Either the patient's nose is very big and large, or the chin is really overdeveloped, or actually the third thing is maybe the lips are very flat and thin. So there's a few things going on. So then we work out what's really the problem here. Make sure that when you take pictures, right, patients' lips are unstrained. So if they're incompetent, make sure they're actually slightly incompetent in photographs, because you don't want them straining. You don't want to ever take pictures with strain. So nasolabial angle, okay, one of the most important angles we look at for treatment planning. Again, you don't need a Ceph. You do this on a photograph. Drop a tangent to the base of the nose, drop a tangent to the slope of the upper lip, and you look at that angle, okay? You don't have to use your protractor or measure it. You really can if you want, but this is an approximation. If it's between 90, 100, 120 degrees, it's quite a good angle. You know, as that angle changes a lot, then we need to work out why. Is it the teeth that are procline? Is it the lips? Is it the nose anatomy? So everything is relative. You know, when you see an angle, doesn't mean one thing. It could mean three things, because that angle is connected to three different areas. So, you know, then we work out. But at this stage, record. Again, make sure lips competent, at rest. So they're not straining. You should never see this strain in a photograph or an X-ray. So some people like to take these oblique 3/4 views with smile, without smile. I don't mind them. In fact, at this stage of learning, I think, you know, the more you do, the better. I don't routinely take these, but I will for a more complex case or someone that's very procline. And, you know, I will take it sometimes when I know that this will be a publication. So, you know, but you can do it, and you can add them to your PowerPoints. Even though we've given you a template, you can add extra. What you're really trying to get here is a sense of the smile arc, the incisor angulation when they're smiling. Okay, so it's kind of a nice photo to give you more information. And once we start to look at those photographs, now we've looked at photographs, okay, we start to hone in a bit more in the smile, because a lot of our treatment, right, is aesthetic. So we're going to look at treatment planning for the smile. And what you want to know, firstly, what's very unattractive, because before we start to know what's normal, from our research, from a lot of studies, we know what's unattractive, okay? And most of the, there's actually a lot of literature on this, by the way. So there's a lot of review articles on it. What we know is a very high or a low smile line is unattractive. So if you're not showing enough incisors or showing a lot and showing a lot of gum, that's unattractive. A severe class 2 or class 3 malocclusion is unattractive, okay? Upper lip that slopes back a lot, so very thin upper lip that's very retrusive, tends to not look that great. Lack of well-defined labiomental fold, so the lower lip quite protrusive. Some people have that. They have no labiomental fold on the side. That can look a bit unattractive in profile. Everted lower lips, very little show of the pink of the lips, so that's vermilion display, quite low. That makes it look unattractive. That's why people get fillers nowadays. Extreme protrusions, unattractive as well. Okay, so these are the features of smile that we know we want to change. But smile has a lot more than just teeth. Okay, so it's the shape of the teeth, it's the position of them, it's the size of them. Okay, it's the color of them. It's how the lips frame the smile. Okay, the mobility of the lips, the gingival contours, and the buccal corridors, or the width of the smile. So there's a lot of things to consider when you look at this. And that's why I don't want you to rush straight to treatment planning, because until you get this really grounded, you really can't treatment plan and say it's just minor crowding, let's just fix this. Okay, so you know, what smiling involves is also that emotional expression you have when they smile, the squinting of the eye, the flaring of nostrils. You know, it involves all of this. It's quite a complex thing to measure. But what we know that in a post smile, so when someone smiles like they would on a camera, you know, to look their best, that's the post smile. You should have most of your incisors showing, you know, almost like 80 to 100% of your upper incisors displayed. Your upper incisors generally do not touch the lower lip, but follow the curvature of the lower lip. It's called a consonant smile arc. If they're really flat or reverse, it's non-consonant smile arc. The smile should at least show up to first premolars or even a bit further back. So, you know, we need to, that's an attractive smile. What's an ideal width of an upper incisor? Because when you're treatment planning and you think, you know, the incisors are of different shapes and sizes, well, generally, the rule of thumb is that the upper incisor should be the width of the philtrum. The philtrum is here. It's the V of the lip, upper lip, and the width of that V should be approximating the width of the philtrum. And of course, midlines matter. So midlines need to coincide for a balanced smile with facial. So how do you measure a smile? Well, you want to look at a close-up of the smile, look at lips at rest, look at a close-up with lips smiling, profile relaxed, maybe profile smiling, you know, to give you a lot of different angles of this smile. So this is a patient we finished treatment, and you will see this in courses to come, a very challenging case. But you know, we basically want to measure in very close up. So in your PowerPoints, you don't have to give me a close up, but if you include it, even better. Okay. So you can also look at videos. So this is just me being silly at one of our courses. This is before my nose job, guys. Anyways, so you can see I'm just being silly here, and I'm just doing an emotional smile because, and you want the patient talking with it. Some of you might have done DSD here. Has anyone done DSD out of this BOSS, Digital Smile Design? No? Because the DSD people take the most beautiful photographs and videos. And if you have done it, you'll follow this really well. So Meng's done it, awesome. So basically you'll understand the video recording. Again, the more information, the better. This is all for your learning, right? If you do 2 cases extremely well, it's the pride you're gonna feel, and the standard. So Tom's done it as well, perfect. So you'll understand this video. Now you can just embed this in your PowerPoint, just get someone to just smile or talk with it. It doesn't have to be fancy. And it gives you an idea, okay? So one of, I think Lily's earlier question was posed versus unposed. Look, it doesn't matter. They're both reproducible. It's just easier in the clinical environment to get a posed smile because the unposed is very natural. It's emotional. It's when someone really laughs, so they're about to cry and they're laughing. It's hard to create that in the clinical environment. So we're going to get into a little bit of measuring of the smiles, okay? So first thing is buccal corridor. Now what buccal corridor is looking at this, if I show you my mouse here, is looking at this negative space between the edge of the lip and the buccal surface of the premolar. So you can see she's got some increased buccal corridors, okay? How I know it? Well, you can see it aesthetically, but also with measurements. So I'm just going to clear that. And because I'll say to you, is the buccal corridor increased, or decreased, or good? And how do we know that? Okay, so just going to reduce it all. Just give me a sec. So it's a simple measurement. It's actually quite easy to do. It's intercommissure width. So the width of, and someone smiles, here to here, okay? And the visible maxillary dentition. So it could be canine to canine, okay, intercommissure width. And then, oh, sorry, this is incorrect. I'm very sorry. It's actually visible maxillary dentition width and intercommissure width, okay? And so a ratio of that. So for example, this patient is showing canine to canine or premolar to premolar. You can look at the width here, okay? And you can look at the commissure width. So the entire width of the lip when it elevates. Because it's a ratio, you can do it on a photograph. You can just drop a ruler or a grid. You can do it there. It's just a proportion. Okay, so you drop these vertical lines. What the buccal corridor ideal is about 16% of the smile. If it's only 16% of the width of the smile on either side, it's okay. If it goes beyond 16% and starts to become 20% dark spaces on either side, they become more and more unattractive. So it's something you want to fix. And how we fix it is later on in treatment planning. But right now it's about understanding that buccal corridors can be unattractive. And if it's more than 16% of the smile width, then we need to treat it. There's a lot of research on buccal corridors, actually. This is a very, very good paper that looked at buccal corridors with extraction and non-extraction cases. And this paper's won a lot of awards. It's done in Melbourne by Anna Mayer. Is it Anna Mayer? Yeah. Anyway, so she did 2 parts to this paper. And she really used unaltered facial photos like this, you know, didn't edit them. She had lots of panel of dentists, separate orthodontists, lay people who were rating these smiles for attractiveness. And what she really found that people couldn't tell whether a case had extraction or not. Buccal corridors were not related to extractions, actually. So it's a very good study with a good sample size. It's a prospective study, and it had 3 different panel judging it. So a really, really good study. And what it's trying to say is whether you have extraction or not, the smile width doesn't change, okay? That's because we don't make the bone collapse, okay? It's the teeth we incline. It's not the bone. So now when we smile, there's also a lot of emotion. Now, you know, women have more elevation of their lips than men. So if you look at this male is showing a little bit less of his incisor. The smile is less emotional. So often men will show a little bit less incisor, and they will have maybe 75% of their incisors, right? The upper lip length is also a little bit longer than females. So they just show a little bit less incisor. So for males, even up to 75–50% is okay. For females, you want to see 80 to 100% of upper incisors on smiling. So you can classify smiles as low smile, average smile, high smile, depending on how much incisor they're showing. But bear in mind, there's also a relation of age. So every decade that goes by, our lips lengthen, especially the upper lip, and it thins. So, you know, we are going to show less and less maxillary incisors. So when we're treatment planning based on age, it could be different to treatment planning for a young child or a teen. And you know, they start to show more mandibular incisors. So often in my adult cases, I would actually try to do a bit of incisor extrusion because I know in another 10 years, they're going to show less and less. So often all my mechanics would be to not intrude upper incisors at all, because I know in 10 years it's going to become even less, right? So you want to just keep them down or even extrude them a bit. So age has a lot of other things, like they tend to get more buccal corridors because of facial flattening of the muscles. Some of you here might be doing Botox and fillers and all that stuff, which is great because you can really not only enhance the smile, but also the facial structures around it. You know, aging is different for men and women, so it's not the same. Women tend to become more convex. They tend to have less nasal and chin growth, whereas men have stronger nose and chin growth. So it's a bit different. So a man that's has got retrusive upper lip right now will look a little bit worse in 10 years than a female with retrusive lips, because his chin and nose are going to grow more than a female. So we know those things. So age has to play a little role in treatment planning. Race is also important in Australia. A bit unfortunate. I don't think we see that many racial ethnicities like in America and Europe. But, you know, for example, African Americans will always show more lower incisor. That is their norm. That is what happens. So, you know, it'd be quite hard to kind of treatment plan otherwise. Whereas Caucasians show less lower incisor, and Asians show a lot of sort of lip incompetency and protrusive profiles. So knowing the race factor is also important. So what you want to start really looking closely at is when someone's smiling, the incisor display they're showing, right? And you want to look at, firstly, are they short? So if this is a case that has obviously reduced upper incisal display, when they're smiling, they're showing a lot more lower incisor display. Now, is it because there's an eruption failure? Is it because, you know, the teeth are worn? In this case, the teeth are worn, okay? There's also probably a little bit of gingival hyperplasia, so a bit of crown lengthening and a combination of bite opening and veneers would be what really this patient needs. So treatment planning for cases with short crowns, worn crowns, you know, you have to think differently. You have to look at gingival margins. You have to look at how much wear has happened, and perhaps plan for veneers post-treatment to get ideal aesthetics. This is where I love dentistry, and I miss that because I can get all the teeth in a beautiful spot, but I don't finish the smile in certain cases. And it really makes me upset because that's not a finished case by me, and it's, you know, it's not a life-changing, amazing thing by me. It's actually by the dentist who's done the veneers. So, you know, this is where I think general dentistry is fantastic, where you can actually finish them with resin veneers or porcelain veneers, or DSD if you follow that system. This is just another study, guys, if you're interested in evidence, where we know that extracting teeth doesn't really reduce smile width. So if we have to extract, extractions are done for certain reasons, and you'll go over that throughout the course with me why. Dr. Mo is going to do a lecture of ways to create space, okay? So because he's going to do a lecture of ways to create space, we're going to talk about extraction as one of the ways and when is it indicated. And I think that lecture is on day 1 or day 2. And he'll talk about different ways like expansion, polishing, IPR, extraction, proclination to create space, distalization, another one. Okay, so when we're starting to now look at the smile, I'm throwing so much information right now, but that's okay because we're going to go through some cases, okay? It'll make sense. So just listen, you've got the handouts, and I want you to read it later on. So the facial type. So you want to look at when you're treatment planning, mesofacial treatment planning is different to dolicho, is different to brachy. You know, what is the length of the incisor? Is the patient showing less incisor because the lip is not elevating, or is because the incisors are short and they actually need veneers? What's the amount of gingival display? Is it actually gingiva that's overgrown? Can we do some crown lengthening here? Is it even gingival margins for smile aesthetics? You know, what's the relative relationship between posterior and anterior occlusal plane? So incisal plane and posterior plane. Is it all parallel, or are we looking at canting here? And you know, what's going to happen in 10 years for this patient? So what's the growth going to be like, and what's the aging process going to be like, and how do we plan appropriately, you know, for that time? So it's important to think about these things, okay? So for example, this patient has a cant to her incisal plane, so it's anterior, and we can see it actually goes along the gum as well. So her gum slopes up, and so does her incisal edges, okay? Because we drop a parallel to interpupillary line, and we can see she has, and that's why she was in treatment for the canting, okay? So you can look at all that from a smile shot. Now, Engel kind of believed that, and this is a fallacy, and I'm going to cover this. The very first lecture of course 1 is Philosophies of Orthodontics, where Engel, Tweed, Begg, they all had their philosophy, and it's important for you to know those philosophies because straightwise are just based on one philosophy. It's not based on, you know, Begg philosophy is completely different. So I want you to know those differences. So we're going to talk about that. But what Engel said, who was the father of orthodontics, that if we put all the teeth in class 1 and everything was as perfect as this, that, and all the teeth were present, we didn't do any extractions, that basically everything would follow. The soft tissues would follow, the bone would follow, and the bone would grow. We know that to not be true now because there were so many cases of Engels that have relapsed and they were treated later on by Begg and Tweed. And there's quite a lot of documentation of all the relapse of Engel because everybody was non-extraction. So, you know, that is not true. Aiming for class 1 is not the most ideal thing. What we need to do is aim for smile aesthetics. So let's not get too carried away by class 1 occlusion, okay? Now, you also want to look at the AP relationship of incisors to facial aesthetics. And this is where Cephs really help. So Cephs help in screening the airway. They also help in really understanding the angulations for procline or retruded incisors, which sometimes you can't get from a photo. You know, you can kind of see it, but you can't measure it. So Cephs kind of really help when you've got incisor retrusion or proclination, and that's when a Ceph is warranted. Here's the thing, if we're gonna treatment plan someone, if you notice my class 1 and class 2 flowcharts, one of the decision was lower incisor. Is the lower incisor proclined? And if you said yes, it was like, don't do this. If you said no, I'd say, okay, this is a simple case, right? It's because we know lower incisors are the most, how do I put it, the most delicate teeth. They have the thinnest root, the thinnest bone in front of them, and they have the thinnest gingiva. So they're more likely to have recession, okay? And the more you procline them, the more likely that recession is. The more likely lip pressures push it back, so it's more unstable. So when you push something outside its zone of equilibrium, as Prophet talks about his equilibrium theory, which again you will learn in courses to come, you can't push the teeth outside of this equilibrium of soft tissues. And if you do, and don't retain it for lifetime, it's unstable. We know that about 40% of lower incisor proclination, we do relapses over time, even with bonded retainers, right? So unless you had occlusal coverage every night and bonded retainers, that's probably the only way to keep it there. So they do relapse. So basically, you can change the proclination, but you've got to understand the effects of it on the lip. If the lip is already kind of quite protrusive, you don't want to make the incisors more protrusive. You also want to look at the balance of the bone, like how big is the chin. The more forward the chin, more easily you can bring the lower incisors forward. So considering all these things in your diagnosis is so important, because when we get to treatment planning, we know how much we can push the boundary for this case, okay? No case is simple. Even a simple class one's not that simple. So if you really look at stability, everyone should have lifetime retention. But not many people wear it for the rest of their lives. So that's why we don't want to really procline everyone's incisors. We want to try to keep them in a nice balance in the neutral zone. You know the best position of teeth? Does anyone know the most stable position for teeth? It's a philosophical question here. Well, the most stable position for teeth is the current position. The moment you move it outside of where they are today, that's when they're going to relapse. So, you know, we try to always do, because we know lower incisors are that bit delicate, we want to try to keep them as much as possible in the current state, except if they're truly very retrocline or truly really procline. That's when you do have to change it. But generally, you want to keep them where they are, okay? You know, extractions have been accused that if you extract teeth, you actually reduce lip protrusion. Highly variable statement. It actually depends on how thick someone's lips are, the lip tone. If you look at some of the Asian population, you know, Vietnamese, they have beautiful thick lips, and even African Americans. And even if you did extractions for them and you tried to retract the incisors, their lips don't always follow 100%. They still look a bit protrusive, right? So it's not a 1:1 ratio, and it varies from race to race. In a Caucasian, maybe it's a bit more likely, because Caucasians tend to have thinner lips, right, more than other races. So if you were to do extractions, and now extractions aren't the problem if there was severe crowding, it's the loss of anchorage. If you really retracted and lost your anchorage and didn't get good angulations of your incisor, that's when it causes a problem. So we don't really understand the difference between exo and non-exo so much right now. But we know non-extraction is quicker treatment. It's more pleasant for the patient. They don't have to go through a procedure. So often it's the most sensible approach nowadays. You know, we have understood, we have so much research now to show how much expansion we can do, what are the limits we can push. We have long-term stability data on a lot of the treatments that we do. So, you know, we do understand that. So, and we'll go through that in time to come. Now we're going to get into treatment planning, okay? So we've been talking all about diagnosis, smile, looking at this, thinking, talking about the age, looking at the race, looking at extraction versus non-extraction, buccal corridors. But if we get down straight to treatment planning, okay, the first thing we're going to look at, which we are all inclined, is teeth. Where do I put the teeth? What should I do with the teeth? Right? Should I be class 1? Should I leave the class 2? Should I leave the midline off? I will cover that. I think I'm going to have a bonus webinar on, you know, I have a beautiful lecture I give, and it's Sorry, I'm going to pause here because Tom's asking a question. Would exception for stability of teeth be cases that have occlusal dysfunction and so can benefit from ortho? I don't understand the question. Would exception for stability? So occlusal dysfunction means, I suppose, grinding. Or, I mean, do you want to speak up, Tom? I don't know if you can. You can unmute yourself. Let me see if you are. Yeah, do you mind unmuting now? I'm just allowed to talk.
Yeah, hi, Vandana.
Yeah.
You said the stability is best left where the teeth originally are.
Yeah.
But in some cases, patients have like weird grinding, things like that. Those patients wouldn't be considered stable in that position, right? Like,
right. Yeah. Okay. Now I understand. Yeah. I mean, if they've got parafunction, that's a tough one. And this is where, you know, to be honest, parafunction has nothing to do with class 1. We believe that lock and key class 1 is going to protect, it's protective occlusion. It has nothing to do with that. Parafunction can just be a resultant of actual erosion of teeth that's lost cuspal guidance, or, you know, it could result from other things like really strong masseters, strong muscles, clenching. Clenching is one of those things that's not bruxism, but it can cause wear facets. And so that's a hard one. And, you know, what you want to do is basically just look at neutral position of the teeth as much as possible. So not moving them too out of the zone. Because once parafunction sets in and it's significant, it's hard to lock in any occlusion. This is a restorative case then. If I would say just do ortho to align and do restorative for the occlusion.
Okay.
You know, but ortho-wise is not. There's a paper that I've put in e-learning portal. In about half an hour, I'm going to finish. We're going to have half an hour to chit-chat, guys, because I really want to go over Slack. I want to go over how you're going with the e-learning. So one of the papers I've put, and if you go into your e-learning portal, go right to the bottom, there's files. And under files, you see this paper, 6 Keys of Normal Occlusion. You can download the PDF. Can I recommend everyone who does ortho to read it? Because this is the hallmark of all the bracket systems. This is what Andrew, and this is such a, it's an opinion-based paper. All Andrew did, he started the straight wire, right? All he did, he looked at 120 casts of ideal patients with normal occlusion. Took him 5 years across 2 countries to find this. So ideal occlusion is so rare. Class 1 ideal occlusion hardly exists in nature. So he took 5 years to find these. Okay, so he found 120 casts of mostly Caucasians who had ideal occlusion. And he said, look, what is the common factor here? Like, what is so good about these occlusions? And then he looked at some Finnish cases, about 1,000 Finnish cases that had won a lot of clinical awards. And he said, what is the common factor between these? And he came up with 6 keys. And those 6 keys are really, really important. And everything in straight wire is built around the 6 keys. They're also a guide to finishing, a guide to treatment, planning treatment. Simply, it's an opinion paper, and it has one of the biggest impact in orthodontics. It has no statistics in it. So what he said was that people who are finished well or have a good occlusion, you know, what is an ideal occlusion? Well, they've got good interarch relationships with their class 1. He believes that their crown angulations, the tip, the mesiodistal tip, there's certain degrees he talks about each tooth, right? The tips have to be correct. The inclination or the root positions, buccolingually or buccopalatally, so that it's called torque, right? It should have correct crown inclination. Now back then, Andrews wasn't looking at Cephs, he was looking at study models. So he deduced torque tip from study models without X-rays. So, you know, it's quite a fantastic paper. He said, you know, there should be no rotations in the mouth, there should be tight contact points and a flat curve of space. So if you have a deep curve of space, you need to flatten it to get a really nice ideal occlusion, which is class 1. So these have become guides to bracket prescriptions, these guidelines. It's quite a big paper. I really, look, even if it makes no sense to you, just have a quick whiz through it. You should really know it, you know. And has anyone read Andrew's 6 Keys, just out of curiosity? Or anyone knows about it, this paper? I'd love to know if other courses talk about it, because this is the basis of full orthodontics. Yes, Justin, so where have you come across Andrew Six Keys paper? Nice. Tom, where have you come across? Undergrad. Nice. Okay. All right. Good, good, good. POS. Okay, good. Ortho long courses use it too. Yeah. You know, I reckon most courses run by ortho will, or orthodontists, okay, ortho as well, will talk about Andrew Six Keys. This is the basis of everything. So anyways, I just want you to flick through the paper because I'm going to go through it with you in finishing in course 3 and it'll make sense. Okay, but here's the problem, right? Andrew's told us this is what we need to do. And all our fixed appliances, the prescription in every bracket is based on Andrew Six Keys. The straight wire appliance is based on it. But this is the problem, that even with the best of operators, we're not able to actually finish well with these keys. So the key one, which is the molar relationship, the mesiobuccal cusp of, actually Andrew's definition of class 1 is different to Engel's. For Andrew, it's the distal buccal cusp of upper molar, dips between the embrasure of the lower molar first and the second lower molar. So it's a different definition. And, you know, to get that AP position of the molar correct, 87% fail to achieve it. So, you know, it's important to know, but what we really do well is flatten that curve of speed. And that's why smile arc protection is very important, because we're very good at just flattening everything. That's what straight wire does. We're just good at everything just looking straight, and we destroy the smile arc. So it's important to keep that in mind when you look at straight wire. So the 6 keys are like an ideal target. It's pretty hard to get, but it's a good clinical aid for you to look at. This is where I want to finish, okay? There are limits. You don't have to, in a nutshell, there's a big lecture I give on this. Not everybody has to finish in a class 1 occlusion. As long as there's no wear, there's no grinding, there's no parafunction, especially if they come as an adult, okay? Growing child is different to an adult. There is no evidence to say that a class 2 occlusion is worse than class 1 when it comes to function like swallowing, when it comes to stability. There is literally no evidence that class 1's better in a lot of ways. Even TMD, there is no evidence that class 2 is worse than class 1. So often in an adult, the question is, should we even try to correct a full class 2 occlusion? Should we accept it? And often that is okay, right? In children, probably not okay, because there's an opportunity to correct, so why not? You know, I won't go into this too much in detail. It's in your handout, but you guys are the king of, you know, veneers, and you know a lot about gingival panel. Okay, Meng, great question. What about class 1 canine? Great question. Actually, there's prosthodontic research that shows, we're going to teach you what half unit class 2 is, because there's a full unit class 2, and half unit's kind of in between class 1 and full unit class 2. The limits of normal occlusion are half unit class 2, as long as there's canine guidance, right? Because if you have a full unit class 2, there's a chance you don't have canine guidance, you have group function. So as long as you have some good canine guidance, if it's half unit class 2 or class 1, it's okay. Again, in a child, it's easy to correct, so you want to correct it. But in adults, it's okay to leave it like that. I won't go too much into tooth proportions. You are the kings of this, okay? But just know that tapered teeth, when you're going to straighten them, they're going to have more dark triangles. Females tend to have more curvy teeth. Males tend to have more square teeth. So when I do my IPR, I do it accordingly as well. You need to know the width and height ratios of each tooth. I won't go too much into this because I want to go into cases. But generally, you know, the central incisor width to height ratio is anywhere from 75 to 85%. So you want to recreate that for a smile, right? So if it's a lot of tooth structure, you want to put veneer. If it's actually altered eruption, you want to erupt them. And you want to correct what the problem is. So we also know when we're planning, when we start getting into treatment planning, that digital setup of the smile, you want to know how much the connectors should be. So as we go distally, the central incisor, 50% of its mesial surface is the connector where the two teeth meet. But as we go distally, it starts to reduce, 40%, 30%. So we know how to create these kind of relationship. So you need this symmetry. Now, one thing, please don't look at golden proportions, because golden proportions have known to be quite unreliable for smile aesthetics. So the golden proportion is only found between centrals and laterals in only 17% of the cases. There's something called that digital smile design people talk about, DSD talks about, called recurring aesthetic index. And that's kind of a better index than golden proportion if you want to look at getting the veneer sizes right. And I won't go too much into it because we'll have Fadi at some stage. Fadi Yasmin do some DSD webinar for us, and or either come to course too. So you will, you'll get bonus webinars throughout the year as well, as we see that there's need for it. So he might come and talk to you a bit about the recurring aesthetic index, but it's kind of beyond my scope in orthodontics to talk about that. So basically, there's a lot of things you want to consider here. Where do you place, for example, missing tooth? What happens? Well, often we estimate the size of it from a contralateral tooth. What happens with midlines? So you can identify the upper. Now, the most stable facial midline is actually the V, the philtrum, the V here, and a line going through that, and soft tissue glabella, okay? That's the most embryologically safe sort of vertical reference on the face. And then you want to look at if the upper dental midline shifted to the left or right, lower, left to the right, of the facial. So this midline I've drawn here is called facial midline. It's not dental midline, it's facial. And you want to compare the dental to the facial. So as a rule of thumb, they should coincide. If they're within a couple of millimeters off, generally patients won't even notice it. If they're about 4 millimeters off, patients will notice it. So that needs fixing. So discrepancies are not detectable mostly to lay people until it's off by 4 millimeters. So again, if there's a small lower midline shift, and it was the sake of finishing early because the patient wanted it, I'm happy to accept if it's within 2 to 3 millimeters. I won't go too much into inclination. Everybody thinks teeth differently or understands smile aesthetic differently. There is a little bit of subjectivity and art to this, but when I design my digital setups or treatment plans, I like my canines quite upright. I like them 90 degrees to the base of maxilla. Some people like them a bit tucked in. Some people like them a bit tucked out. It's just like, how do you design your veneers? So, it's really an operator specific thing as well. You'll have people say, I like, a couple of degrees tucked in, my canines and premolars. I like them all a little bit upright. So it's just one of those things that you learn to kind of go, this looks good and I like this. And you have sometimes brackets with different prescriptions that tuck in the canines, tuck them out, and you can, use 0 degree plus or +7 or -7. And it's up to you. Just be aware of the biological width of teeth when we're designing treatment planning. If they've lost a lot of periodontal bone structure, we need to treatment plan very differently if the periodontium is ideal. And that's because the biological width is influenced or compromised. You also want to look at the gingival levels on contralateral teeth. So one central might have higher or lower, and work out what the problem is. Is it eruption issue, or is it the fact that we need crown lengthening? And always the lateral incisor, the gingival contour is slightly lower than the centrals and canines. So we know that from a lot of our aesthetic dentistry. And again, I won't go too much into this because you kind of know this. So how does all this information kind of come into your 2 PowerPoints? Firstly, as I said, a course 1. After course 1, I doubt you're going to have too many questions, okay? Between now and course 1, I'm happy for you to throw pictures at me on Slack, which I have had a lot of people do. Firstly, make them great pictures. If you can't, that's okay. I'll guide you, watch the video. I'll tell you what equipment to get. Secondly, if you just send me a picture and don't give me some sort of examination form or something, I have no idea, because this patient might want a 6-month treatment or might want a 12-month treatment or doesn't want elastics, or there's a lot of variables here. And until and unless I get those 2 forms, it's hard for me to sometimes decide. But if it's just to screen and say, you know what, this is a good case for you, yeah, go ahead, that's okay. You can throw pictures at me. But when it comes to making your PowerPoint, make it very slick. So because this is not only assessed by me, it's also assessed by Dr. Mo Al-Muzian. It's also audited, right? It's not like me just kind of saying this is great, get the postgrad diploma. It's all audited according to our marking criteria. So here's an example of an attendee from last year who did her, I think this is a guy, sorry, who did his PowerPoint. And we've got, you know, and you can change it around. We've given you a template, you can add to it. So she's basically got a frontal rest and a frontal smiling position photograph here. But we've also got some extra photographs to really show the 3/4 smile, the profile smile, close-ups, as well as a bit from the distance. So they're nice shots, not just we can see profile, we can see 3/4. You can see that they also took pictures of the teeth because there was wear on the low incisors. So teeth apart is not a bad frontal picture to take, but you also want the frontal and occlusion. Look at the amount of retraction, okay? Everything is really well retracted. The light, because it's a ring flash, is going all the way back to the 6s. And I want all of you, and I'm sure there are, you know, I think half the group here is very experienced. I'm sure some of you here already kind of take amazing photographs, but for the purpose of the diploma, they have to be really good. So you want to get these. Look at the reflection here, okay, the side buccal shots. They're taken direct. They weren't taken with a mirror. And you're not just putting one retractor, you're putting both retractors, but stretching one out. Watch the YouTube video, okay? It's going to give you tips. Upper is presented nicely. It's flipped. It's exactly how I want to see it. The lower, not so good because they didn't use a lip retractor here. So you can see when you just use the 2 retractors, it doesn't work. We're not seeing half the incisors. You know, they're being covered by the lip. So we really want a lip retractor to pull that down. Nice OPG, you know, and here's the analysis of the case. What's the chief complaint? What's the medical history? What are the expectations of the patient? You know, what's the dental history? What's the dental treatment so far? Any habits, any considerations? Like here, a patient has a strong gag reflex. They don't even want braces. They feel something in their mouth, so they want Invisalign. Then we're looking at a frontal analysis. You know, is this a symmetrical face? What are the widths? What is the length of the face? We're looking at whether this is a dolichofacial, whether this is, you know, mesofacial. He is quite a tall, narrow guy, so it's easy to think he's a dolichofacial, but actually look at his bite, right? Look at his occlusion. It's deep bite. So he's actually mesofacial. So he's just quite a tall, narrow guy, but I think he's quite in proportion. So we believe he's mesofacial. Now, again, you could get this wrong. I could get this wrong. Doesn't matter. At this stage, it's just about giving it a go. Facial type, what's the lip pattern? Is it strained? Is it incompetent? You can call it whatever you want, right? Descriptor is a descriptor. Breathing pattern, TMJ, are there any clicks? Are there any locking of the jaw? Any jaw pains? Speech. By the way, orthodontics and TMD don't relate that well, and Mo will do a lecture on that in course 1. Smile analysis. So this person has gone ahead because this person used to do DSD and kind of drawn the cross of the DSD, which is, you know, where it all starts from, and then created an arc. So we can see very clearly here that the 2-2 is actually needs to be extruded. Now, if we couldn't extrude it, probably needs a veneer, but 2-2 needs extrusion here. And we can see very clearly that the 1-1 and 2-1 don't need any intrusion. If anything, they need to be slightly extruded or kept where they are. We look at the width of the smile. The width here isn't bad. It's kind of following the curve of the lip. So we know that we're going to maintain the width and not increase it too much. And so we have to then find space for crowding, not from expansion, but from either incisor proclination or interproximal reduction in those kind of ways, right? So we have this analysis here of what the incisor edge position is, what's the lip line. Now, I would call it a consonant smile arc. You can call it normal. Gingival display, you know, it's low. He's not showing gingiva at all. Color discrepancies. Has he got like one tooth really yellow? Because that matters as well. Size discrepancy. We think 2-2 is a peg lateral. What's the midline? It's acceptable. It's within 2 to 3 millimeter off. Curve of speed, nice curve of speed. I would call it deep. But you know, at this stage, it's just about having a go. So you can just write whatever you want and we can change it, right? Because once you prepare to this level, that's when I'm going to actually do a 1-hour 101 with you and fix it. So for the first step is getting it to this level. And you can see that this person's now analyzed the profile shot. They're talking about the profile, nasolabial angle, lip projection, mandibular plane angle. You know, again, this participant, this dentist felt that it was high, but actually it's just a tall guy with natural equal proportions. So we think it's normal. What's the chin prominence? And these are things in course 1 we're going to go over. How do you measure chin prominence? How do you measure throat length? How do you know? And you'll realize some of this is quite subjective. But at the same time, you know, if we're all talking the same lingo, it's important. So midline, is it the lower to the left or upper to the right? So here, the lowest to the left. What is the occlusion at the moment? You know, it's class 1 on both sides. What's the overjet? What's the overbite? What's the amount of crowding? Is it mild, moderate, severe? Is there spacing? You just have a go. At this stage, you don't have to measure everything to perfection. Rotations, you know, where are the rotations at the moment? Because rotated teeth are difficult to correct. So you want to know the rotations. You could even try to have an estimate. For example, 3-2 here looks like it's rotated about 45 degrees. So we know it's quite a severe rotation. So you might want to measure, you know, just have a visual of it. So here's what happens. Once we look at all these things, right? We go back to the slides and we go, what's abnormal here? Class 1's normal, class 1's normal. The overbite 60%, that's abnormal. It should only be 10 to 20%. Okay, midline to the left, that's abnormal. Once we know what's abnormal, we throw it into something called problem list. Okay, problem list is nothing but everything you found from all your diagnostic records, including x-rays, including study models. This is just a short version I'm showing you. This is the first version you're going to do. You want to list it, okay? And you want to list it in a way that I teach, and that is look at 4 things. What's the problem here skeletally? What's the problem here dentally? What's the problem here soft tissue and quality of life? When you look at skeletal, you look at 3 dimensions. Transverse, is the jawbone okay? So is the width of the maxillary base, the skeletal bone, okay? Often if they don't have a crossbite, it usually is. Again, it's variable. Is the anterior-posterior position of the jaws okay? Vertically, is it normal? Right? Dentally, you want to start looking in 3 dimensions as well. What's the occlusion like? What's the vertical like? Is there a deep bite? What's the transverse like? Is there a crossbite? Then soft tissue. Soft tissue could be a frenum. It could be a short upper lip. It could be gingival recession that's quite severe, right? It could be PDL issues. So you want to mark it right now, just list everything. So we've listed everything here. We've kind of looked at tooth size. You know, we know 2-2 is peg lateral, probably even under erupted. And lastly, you want to look at quality of life. What is the problem here? Now, this patient has the confidence, so he's coming to treatment for confidence, increasing the smile confidence. But it could be that this patient's traveling a lot or doesn't have enough time to come to appointments, and that's when clear aligners suit them a bit more than fixed appliances, or that they want as invisible a solution. So again, that problem list becomes important, okay? Because what we're gonna do after the problem list is come up with a little summary. Now, Mo has his own way of showing you how to do a summary. I kind of just say, throw it in. Just throw everything you see that's a problem right now, just put it there, okay? So just put it there, and you basically now need to work out, what are we gonna correct? What are we not gonna correct? So I've got a question here before I keep going. Do we have to have a checklist of the items need recording? I don't understand, Fani. And do you want to come on the mic and ask me this? You've got, I announced before, you've got the examination form and your templates to guide you. Are you able to come on? I don't understand the question. Okay, we'll come back to that later. I can unmute. You can or can't. Hang on. Let me see. Okay, Franny, you can talk now.
Hello, Vandana. I was just wanting to know, like, about all the items of what we need to record, like, say, you know, the soft tissue or the hard tissue. Do we have just a checklist?
Yeah, so that examination form I showed at the very start, those 2 pages, that's the checklist. If you actually look at that, that's in Boss Downloads, right? It's got everything. It's got canine relationship, it's got PDL, it's got TMJ, it's got everything. And at this stage, you don't have to know it 100%, but if you try to fill it out to your best estimate, that is better than nothing. So if the estimate is incorrect, that's okay. We can work on that together. We can say, hey, I don't believe this is, you know, actually brachyfacial. I believe this is dolicho, or, you know, we can talk about that later. And this is where you start to see that cookbook stuff doesn't work, when you start to see the complexity of each case. So I hope that answers. Go look at those 2 pages that they actually give you. And there's actually another 2 pages in that form. So there's total 4 pages. And the last 2 pages have got this table. So you can start to write things, you know, so you can have this for every patient. Okay. All right. So you're welcome. So basically now we're looking at those 4 domains still. So think of your problems in 4 domains: skeletal, dental, soft tissue, quality of life. What I've tried to do here is given you some major points that we need to write. So what I want to see here, skeletal, if you think the transverse is narrow, if the maxilla is narrow, write it down there, narrow maxilla. If you think it's long face, write it down there. If you think mandibular retrognathic, write it down. Dental, how much is the crowding? How much is the spacing? What's the canine relationship? Class 1, class 2, write it. Just right now, just write it, okay? Lip competency, good. Smile aesthetics, what's not right with the smile? Habits, incisor display, very important, probably the most important thing. Quality of life, just write it. Because when you write that, you're then going to develop your treatment plan. You're going to say, am I going to change the skeletal? For this particular patient, we thought everything was pretty good. It was class 1, it was pretty good. The AP projection of both jaws was good. So skeletal has no aims. We're not doing any treatment plan here to change the skeletal base. What we're going to do mostly is dental. This is also a good kind of checkpoint for you, because if you're not treating skeletal problems and you're treating dental, they tend to be simpler cases. So if you're starting out with your first case, or, you know, try to choose one which doesn't have much skeletal issues. So dental, for example, there's crowding, spacing. So we've decided in this case, we're going to procline the lower incisors a little bit because it's deep bite, they're quite retroclined. We've looked at the Ceph, and we also think that the 2-1 and 1-1 were a bit retrusive, so we were going to procline. Deep bite, now we know deep bite is a dental issue here. What are we going to do? How are we going to fix it? Well, we've decided to procline both incisors a little bit because, again, we felt that maybe more the lower incisors than upper. At this stage, I don't know. Maybe lower incisor intrusion, okay, and lower posterior extrusion. Smile aesthetics, what are we going to do? We're going to align the lower teeth. We're going to build up 2 peg lateral, most likely, maybe mid-treatment, to make sure we finish well. You know, how are we going to gain space for the peg lateral build-up? Maybe move to 2-3 distal. So we're planning these things now, right? Quality of life, Invisalign's choice, clear aligner is going to give him the confidence, and he's got a gag reflex. He wants no impression, so maybe scanning is better. So thank you to our sponsors. We have so many sponsors come on board. I'm very, very excited about them.